Okay, good day, Anne, and thanks for joining me today.
Hi, thank you for having me.
Absolutely. Can you introduce yourself, please?
Sure. My name is Anne Shaknis Quirk. I'm a speech language pathologist in Providence, Rhode Island, and I have a private practice that specializes in neuro rehab and voice.
Great. And when did you take the class? I'm sorry, I don't recall.
Yeah, I took it in the summer of 2021 in Exeter, New Hampshire.
Okay, all right, great. During our mask period there. Yeah,
Yes. Yeah. Yeah. It was an interesting time, but so helpful.
got it. So, you actually asked if you could do one of these because of the population that you work with that had not yet been included in any of these videos. So I really appreciate you reaching out to me on this. Do you want to share a bit about your population, possibly how this work seems to slot in with all that?
Sure. So I have a very large amount of gender diverse clients on my caseload. One of my specialties is gender affirming voice therapy. And have found these videos really helpful and love hearing how other therapists are utilizing manual therapy in their practice, and thought that I might be able to help some other people either learn about gender affirming voice therapy or how to incorporate it.
Perfect. So how does manual therapy supplement the work that you do?
Yeah. So when I have clients come to me, some people think like, oh, people just come to you because they want a feminine voice or a masculine voice. But
Mhm.
oftentimes there's a wide range of what people are looking for to help them align their voice with their gender identity. And sometimes I have people come to me right off the bat and they say, I've been thinking about this a long time and I wanted to come to somebody so that I don't hurt my voice. And other times, because there is often a lack of access to care, there's a lot of people who do YouTube videos or online videos in order to try to modify their voice. And sometimes that creates a lot of tension and can lead to a voice disorder. So I often have clients coming to me who are already having difficulty with their voice because they've tried to modify it on their own. So one of the first things I do with all my clients is I teach them about the anatomy, what we're going to be working with, how we're going to modify things based on what they're looking for. And then I show them how I do manual therapy. I do it with my clients in front of a big mirror in my office, sitting upright in a chair with me behind them. But I also show them how that they can use it at home on themselves during the week, because they have home exercise programs that they really need to stick to. And oftentimes we're introducing a lot of tension because we are changing the way the muscles are working. So we're not changing the way the muscles are working, but changing the positioning of the muscles and trying to
Mhm.
keep muscles in certain places that they're not used to being. So we kind of have to build those muscles up. So I'll give you an example. Resonance is kind of one of the pillars of gender affirming voice care. And my trans mask clients often want a deeper, darker resonance, and my trans feminine clients often want a brighter resonance because darker resonances tend to be perceived as more masculine, brighter resonances tend to be perceived as more feminine. So when I'm working with a trans feminine client, we are often trying to raise the larynx up and keep the larynx in the higher positions so that we are kind of making their instrument smaller and therefore brighter. So we are doing silent E's where they're lifting up. Sometimes we're even doing swallows and keeping the larynx raised. And we're doing that progressively longer and longer until they're able to keep their larynx in the raised position all the time and speak with it in the raised position comfortably. So we do a lot of, semi-occluded vocal tract exercises, everything to reduce tension. But I have found that getting in there myself every week, trying to help them release a lot of the tension that gets built up while they're practicing this throughout the week is very, very helpful. On the other side, my trans masculine clients, we're trying to increase the length and size of the larynx so that there is a darker quality to their voice. So we're trying to relax everything, let everything come down. Sometimes depending on the person, listening to their own voice can be very dysphoric. So there's a lot of kind of tension that just builds up naturally. So trying to get in there and relax the larynx so that it can open up and they can really access those darker sounds.
Well, that's brilliant in terms of how you've chosen and to incorporate this. That's really nice. You know, since you took the class, which is 3 years ago now, you know, even more so than when I was teaching it back then, the realization that this touch-based work is so much more than just, and not to discount or to disagree with what you said, but it's so much more than just having a resting change or a use change of higher or lower, which kind of aligns really well with some of the existing evidence on manual circumlaryngeal work, right? That manipulate the larynx and lower it for a more resonant voice, et cetera, which is certainly a part of it, right? But it's so viewed as a function of what happens here versus what happens here, right? Because when we do this work, when you do this work, I think a lot of it too is not about possibly not creating a lasting change in where the larynx rests or where it's actually resting while they're talking, but in addition, giving the each individual client the idea of the awareness of what they need to do to make that sound, right? It's not just a result of right here, but it's central nervous system, autonomic nervous system, awarenesses, sensory input, motor output changes that they give each individual the option to say, I can choose to do this in a different way, whether it's the voice reassignment or somebody coming in with muscle tension dysphonia, giving them the idea that it's not just about what's wrong here, it's about helping to shift things from here to here. So just so encouraging to hear how you've navigated this independent of the model that I teach, which is just exactly how I want clinicians to lead my work. Not as here's how you have to do this work to manipulate this, but here are ideas to then translate on your own and then translate individually to each unique patient. So it sounds great.
Yeah, I that's so spot on. And I tell all my clients, I want you to have the flexibility to modify your voice in a variety of ways. Some people are not out at work, and the only place that they're really able
Mm,
to use a confident, preferred voice is at home or with friends. And I want them to be able to kind of go between voices as they see fit for the circumstances. So having the flexibility to raise the larynx or lower the larynx or make these very small tweaks based on kind of the ingredients that they want to, I tell them, we're like building a cake. So you get to pick and choose which ingredients and how much of each ingredient you want in your preferred voice.
mm,
But to be able to access that takes a lot of trust in themselves and allowing themselves to go to these places that may have felt very uncomfortable or unsafe to go to prior. I was so thankful that your course really focused on it being very patient and client centered
mm.
and not about the clinician. I tell people that I'm just there to guide them. I'm not there to tell them what their voice should sound like. I'm there to kind of give them all the information I have and then guide them in the decisions that they want to make for their own voice.
Excellent. I'm curious, have you hit any obstacles? Because I I think from a traditional perspective, when a patient, and I don't care what sort of disorder, they come in and they say, okay, you want to manipulate this. Is there something wrong with my tissue that we need to manipulate, right? That transition from this as something that's a skilled intervention where you're going to fix something here into transitioning into something that's like, no, this is almost just an avenue of expression of how to give you options. Has that been a challenge for you at all with any of your clients or patients?
Um, It's been important to look at it not as like a deficit model, where if I have
Mm,
somebody come in with muscle tension dysphonia, we're looking at what are your habits that are increasing this, what's wrong. And so coming at it from not a deficit model, but as just an access to knowledge and how you can healthily and safely modify these little muscles, and cartilages in order to get the sound you want. I think that clients, there's so many different backgrounds and circumstances. And, when I first do the evaluation, I'm doing a really as deep as I can history on what the circumstances are and how they're feeling when they're coming
Hmm.
in, and have they tried to modify their voice before, and how did it go? And sometimes I have clients come in who went to another speech pathologist who maybe wasn't trained in this particular way of modifying voice, and they didn't have a great experience. So there's sometimes trust building that needs to happen. Um, I also think it's important to acknowledge that this community is often exposed to a lot more violence.
Hmm.
So when I'm doing manual therapy, the consent and the explanation is so important. I always talk about, even before I sit them down in the chair and face them in the mirror, this is what I do, this is why I do it, this is what would happen when we're ready to start, consent, asking if I can put
Hmm.
my hands on their larynx, and then really trying as much as I can to get as much feedback of them so that they're making the decisions as we go along.
Perfect, perfect. I know here in I'm in my clinic right now in upstate New York, and whether it's somebody coming in for voice or more general issues, sometimes that like trying to understand what it is we're trying to accomplish here, it can be a challenge. Some accept this fuzzier version that I explain, right? That it's really complex what we're doing with touch, as well as what we're doing with all of our interventions, because some of them are so steeped in that, let's break up this knot or this trigger point or something physical that you can at least put your attention on. And occasionally I struggle with it with my patients. It's like, yeah, you people want to believe that there's pathology right here, and while there might be, there's so many other avenues of input of influencers of change. Do you find that a challenge for yourself?
I think that, with this community, I often talk about holding emotion
Mm,
and where we hold emotion. And when they come to see me, a lot of times they're in the middle of making some really big changes in their lives. And so there's a lot of emotion kind of held in
yeah.
that area, and talking about like, making it accessible for them to understand, because I didn't understand it before I really started delving into it. But when you're about to cry, what's the first place that starts to
Mm,
feel really tight? It's
yeah.
often your throat. So I think like making those connections allows people to realize like, oh no, this is something that I should at least look into or try out. And then I feel like after the first time we do it, um, I'm always checking in, asking them how they feel, and it's always a positive response. So it's like if you have a good experience doing something and it allows you to kind of almost settle into the other parts of therapy that we're doing, like why
Right.
would you want to keep doing it?
Yeah. Yeah. And since I think, yeah, I'm pretty sure since the 2022 class, um, I've incorporated concepts that Leah Halou uses with her transgender voice work, not necessarily the techniques, but that concept of metatherapy, right? That people come to us thinking, they come to my class thinking that the magic is in the specificity of the technique, which is which is true to a certain extent, but it's how we envelop, how we surround it, how we present the contextual factors of everything of the therapeutic relationship. And to me, being gifted that word, if you will, the metatherapy, and an understanding that the approach that I'm trying to teach is not just about this, but the meta as well. And it sounds really like you just sort of ran with that concept with your patients, and it's worked well for you.
Yeah, I love working with them. I feel like it's been such a gift. And it's been wonderful to kind of take different things I've learned over many, many years and incorporate it. And this was one that's been really, really helpful.
Cool. Any got a story you want to share?
Oh gosh. I recently had a client who um is very in touch with themselves. They are a fire dancer, and so they were really, really interested in, they saw on my website that, not only do I do gender affirming voice therapy, but I also do manual therapy. And they were just so excited that I did that. And they said, can we do it every session? And I said, yeah, I'm happy. I want you to be able to see what I'm doing. I want you to be able to do some circumlaryngeal massage on yourself during the week. And I feel like they really ran with it. And, every week when they would come to see me, they were like super excited to get into it. And so just having somebody who was really, really excited about it, was so nice.
Very nice. Yeah. So the elephant in the room is often, especially with new learners, it's like, okay, how do I actually start doing this thing that my profession doesn't teach me how to do typically, right?
Yeah.
Was that awkward, or do you have any like possibly even advice for somebody who's either considering it or maybe taking a class, but still there's that hesitancy to include it until I'm really good at it, which I think is a big mistake. Get good at it with the people that might help you get better at it, right?
Yeah. I think, for so long I worked in hospitals and in home care and in subacute. And I think when I opened up my own private practice, it really allowed me, but also forced me to kind of say, like, what you don't know, and you just have to try it.
Mm,
And so I originally had taken the class because I was working for a home care agency that was part of a larger healthcare system that had a cancer center. And I really wanted to be able to help my head and neck cancer patients
mhm.
with a lot of the, trismus and everything that goes along with the treatment. And so I went into it thinking that I was going to use it with a particular population. And now I have found that, once you start incorporating it into other populations, it yeah, it's scary. And I can't even tell you the first time I did it with one of my gender affirming clients. It just felt so natural. Like
Mhm.
it's like you just have to jump in and um, I don't want to say fake it till you make it, but you kind of have to have that mindset a little bit.
Yeah, yeah,
And be confident in the fact that like you're an expert in what you do, and experts need to learn new things. And everybody has to have that time where they're kind of fumbling a little bit, but they know they're on the right track, and they have the consent and the trust of their clients, and you're going to figure it out.
right, right. You know, to me, one of the biggest things that I try to instill on new learners or people kind of interested, or even those who are kind of skeptical, there's I love this quote so much that it's the top of my Facebook page, and I'm only going to be able to paraphrase it because I don't want to pull it up on the screen to read it. But it's essentially, instead of thinking of manual therapy as this thing we do to fix something out here in the periphery, think of it as another form of communication, right? If you like the toolbox analogy and adding a tool, that's certainly apt. But instead of seeing it as a very specific niche thing for only the small segment, allowing touch to be another form of communication that we try to reach another individual with, right? Everything, despite what even the evidence says, we know that every intervention doesn't reach that person. So having a broader range of it without thinking about it as some sort of oh, this only a niche work. I mean, touch is very communicative, especially when it's safe, affective, and appropriate, right, with boundaries and permissions. So I love the way you sort of embodied that approach with all of your clients, not just the transgender ones. So very cool.
Thank you.
Yeah. Any final advice for somebody who might be struggling or interested in learning?
Um, with manual therapy, interested in learning more
Yeah.
manual
Yeah.
therapy,
Yeah. Yeah.
I think, I think just like there's when we go to grad school, there's only so much you can learn
Mhm.
in 2.5 years. And it's really incumbent on us to, when we know that we don't know something, to really find the resources and the people that are experts in that field and learn from them. So I think finding you, going to classes, looking up research articles, just educating ourselves. It's a continuous, in our field, like there's new stuff coming out all the time. And I think it's so important for us to stay on top of it. And I think taking your class was just, like I said, I went into it thinking I was going to be using it with one population. And while I still use it with that population, it's been so, so helpful in a variety of my clients.
Very cool. One last question, then I'll let you go. Do you feel like you found the work sufficiently evidence-based, evidence-informed to feel like you're not straying too far from your professional scope of practice?
Yeah, yeah. I mean, so much of what I do is very, very evidence-based. I
Mhm.
have, I have a blog on my website and I take research articles
Mhm.
that are newly published and I kind of go through them and write about how they're applicable to my clients. And I think that it's so important to have evidence-based practice, and there's so much evidence behind manual therapy, but it's
Mhm.
also important to just look at the person as the person. And if you know that with one of your clients, something is helpful, um, help them.
Yeah,
If
yeah,
they're coming to you because something has been helpful, use your evidence-based practice, but also incorporate things that are going to help them, whether there's evidence there or not.
gotcha. Yeah. Recently, somebody gave me a really interesting analogy or sort of example that this person, a speech pathologist who was taking the class, saw her profession, your profession, as sort of this graded variable from people really in the centrist, who really stick very rigidly is the wrong word, but very hard and fast to what the evidence seems to define and doesn't. And others sort of filter out and are maybe possibly a bit more comfortable with the fringes, not to ignore evidence-based practice or the norms of a profession, but seem comfortable flexing those boundaries just a little bit. And I thought that was really interesting. Not that, centrists wouldn't find this helpful, but might you see yourself as more of that fringe type person?
Yeah, I mean, I think I'm both. I think it's
Yeah,
important to have both in your practice. I think it's important to be doing things that have evidence behind them, but it's also important to do things that um, are helpful, even if there's not evidence behind it.
yeah, yeah,
Be open to that. I think if we just do things that have, reams of research behind it, we're going to limit ourselves. And I think
right,
that we're not looking at the client as a whole person. We're just looking at them as a participant in a research study. And I think you
right.
have to look at the whole person and really get a sense from them what they're looking for and how you can best help them.
Yeah, great. All right. Well, Anne, thanks so much for taking the time with me today,
Yeah.
and best of luck in the future.
Thanks. It was so
Yeah,
great to see you.
great.